All right. So, a 26-year-old man came with severe pain in the epigastrium since 6 hours, and we did an ultrasound. So, this is what the ultrasound picture shows. Now, you see this echogenic structure over here that we see. That is your pancreas that you see over here, and this over here in center is your splenic vein and your portal vein. Over here in between, this is your liver, and in between what you get is your stomach. So this entire structure is your pancreas, and over here what we are seeing, the echogenicity of this area is different from that of this area. So what is it? It's most likely to be pancreatitis, because pancreas is edematous. It appears more hypoic compared to the rest of the gland. So what we did is we went ahead and we did the CT scan for this patient, and this is what we see. This is the normal appearing pancreas, and this part of the pancreas appears, has a different appearance of the density, as we call it in CT. And there is a lot of free fluid around. And there's a lot of free fluid around the pancreas, which this area is known as the anterior pararenal space. So this entire this is your pancreatic head, this is your pancreatic body, this is your pancreatic tail. And over here what we see is that actually the pancreatic duct is normal in caliber and it is not dilated. And if the pancreas is inflamed, is it due to GB or a CVD calculus, or is it due to a pancreatic duct calculus or not? CT would be the next step, because that is going to tell us whether there is going to be parenchymal necrosis or not, or is there how much of fluid collection is there or not, because all these things are going to decide the management. So after the acute phase has settled, so suppose if the patient comes to you in a chronic phase, that is chronic pancreatitis, or maybe after the maybe 3 or 4 weeks after the acute pancreatitis, and the patient comes with this sort of an appearance. This was a patient with pancreatic pseudocyst. So when we do chronic for imaging for chronic pancreatitis, what we expect is, either we look at the cyst, we want to look at the complications for which have happened due to the pancreatitis. Is there any portal vein thrombosis, splenic vein thrombosis, splenic artery involvement or not? And obviously, like I said, the first thing, is there a pseudocyst or not? So when we see a pancreatic cyst, there are a lot of differential diagnosis, and these would include obviously a pseudocyst, a retention cyst, a pancreatic abscess. A pancreatic abscess might occur, once there's acute pancreatitis and that necrosed tissue gets has a superadded infection. So you might end up having a pancreatic abscess, a lymphoepithelial cyst. Pancreatic cysts are quite common with autosomal dominant polykidney disease, von-Hippel-Lindau syndrome, and cystic fibrosis. Is it a cystadenoma, solid and papillary epithelial neoplasms, and of course pancreatic islet cell tumors. So this was a case over here. What we see, it's in the uncinate process of the pancreas. This is an irregular, heterogeneously enhancing mass. So ultimately, what this turned out to be, adenocarcinoma of the head of the adenocarcinoma of the pancreatic head. So apart from just identifying the mass, how big is it, and trying to characterize a mass. Nowadays, what we need to give is it involving the duodenum? Is it encasing any artery? What is happening to the portal vein? Because if these structures are involved, these will alter the surgery procedures. Now, in a nutshell, while imaging the abdomen, what we'll do is, there are certain conditions which will need special mention. Obviously, I've mentioned these things before, but just to recap, there's esophageal mucosal lesions or motility disorders. Motility disorders, which I mean pressed by motility disorders, what I mean is a achalasia cardia, or a corkscrew esophagus, so or a globus hystericus. That's where you use your barium swallow and video fluoroscopy. Esophageal neoplasms, obviously barium swallow is the initial modality of choice, following which CT neck for local staging may be done. For gastroesophageal reflux, we have barium meal, And obviously radionucleotide studies, as I said previously, especially in pediatric age group, they call it the milk scan. If you're suspecting an esophageal perforation or a tracheoesophageal fistula, you can do a gastrographin study. Gastrographin is a iodine-containing contrast agent, which the patient takes it orally, and if you see that it's leaking anywhere else outside the esophageal lumen or within the trachea, then it confirms your diagnosis. Hiatus hernia, the imaging modalities would be the barium meal and the CT. Mucosal ulcers of the stomach and duodenum. Obviously, barium meal is the modality of choice. A double contrast study would be more helpful. CT would help in evaluating the complications, whether there is stenosis or is there a perforation or anything like that. Stomach neoplasms, CT, followed by your endoscopy. That would be the protocol. Miscellaneous. So for stomach neoplasms, initially barium used to be the modality of choice, but now it has been replaced by CT. Small bowel obstruction, plain radiography will tell you whether there's an obstruction or not. CT will tell you the level of obstruction or if there are any other complications. Barium meal follow through or small bowel enteroclysis is generally done for subacute obstruction to identify the level. Now when I say small bowel enteroclysis, how is it different from barium meal follow through? In barium meal follow through, what they do is they just ask the patient to drink the barium, and you watch it go down as it goes down in the esophagus, stomach, duodenum, jejunum, etc. But in small bowel enteroclysis or the small bowel enema, what you do is you take a tube. It's known as a Bilbao daughter tube. The tube is passed through the nose, through the esophagus, stomach, and it is passed into the second part of the duodenum, or the duodenojejunal flexure, and then barium is infused through the tube, so that barium goes directly within the small intestine, and it is infused at a rapid rate so that there's adequate distension. Another condition would be bowel perforation. Obviously, plain radiography will tell you whether there's free gas in the abdomen or not. CT would obviously tell you what are the other, whether there's fluid or are there any other underlying pathology like a tumor. Abdominal hernias, obviously, ultrasound is a modality of choice, but this is like hernias, your inguinal hernias, your anterior abdominal wall hernias, your periumbilical hernias. But if there's an internal hernia, then the CT is a modality of choice. Appendicitis, ultrasound is very good for pediatric population, and CT for diagnosis and evaluation of complications. When I say complications, what do I mean by complication? Is there a formation of a phlegmon? Now, what is a phlegmon? Phlegmon is basically due to the inflammation of the appendix. There's a lot of inflammation in the surrounding mesentery, the surrounding bowel loops. Ultimately, they'll all form into like one big mass, and this would be a contraindication for surgery. Another complication would be an appendiceal abscess. So once these important complications need to be ruled out, Meckel's diverticulum, CT can be performed for that, and obviously radionucleotide studies would also help. When we think about the hepatobiliary system, if you're suspecting cholecystitis, ultrasound is a modality of choice, and this can be followed up with CT if ultrasound is equivocal. Cholelithiasis, ultrasound is a way to go. Obstructive jaundice, ultrasound, CT, MRCP, and ERCP and endoscopic ultrasound for distal CVD obstruction, for example, periampullary carcinoma. Acute pancreatitis, like I said, CT. Chronic pancreatitis, you can either use CT, MRCP, or ERCP. In chronic pancreatitis, this ERCP is used to stent the pancreatic duct. Cholangiocarcinoma, ultrasound will show you the dilated intrahepatic biliary radicals. It may show you the mass-like lesion. MRCP or CT will help. And obviously, if the obstruction is quite proximal in the CBD, intrahepatic cholangiopancreatography will definitely help. One thing what it will do is it will drain the biliary tree, and the other it might just help in stenting. So after that, we proceed on to the genitourinary system. So this over here is, we begin with ultrasound, since that's one of the most commonly used primary investigations. This is actually your right kidney over here. This is what I'm showing. This is your outline. This is basically the smooth cortex over here. This over here, that's your medulla. So this is how it should appear. So this is your renal cortex, this is your medulla. This is your renal cortex and this is your medulla over here. And this is your liver. So ideally, your renal cortex and your liver should have more or less similar appearance. So when we say that there is loss of corticomedullary differentiation, this differentiation which we see over here, that is lost, and this is commonly seen in medical renal disease, chronic kidney diseases. Why do we use ultrasound initially? Because it's cheap, it does not involve any radiation, and it can give you a fair amount of information. So this was a case where you saw a cross-fused renal ectopia. So that means what we did is, on the right side we scanned, we found an empty renal fossa. But then when you look on the left side, you see a weird looking appearance. So this is your first kidney and this is your second kidney attached to the lower pole of the first kidney. Another congenital anomaly, this is actually your horseshoe kidney. So when you see a horseshoe kidney, you would want to see, are there any calcifications? What is the status of the renal arteries? How is the blood supply? Is there any hydroureter or not? And renal calculi. The renal calculi are actually, picked up by abdominal X-rays, but then there are quite a few calculi, radiolucent calculi, which may also be missed. But these calculi may also be missed due to poor bowel preparation. When I say poor bowel preparation, when there's lots of gas within the colon or the small bowel, which might hamper detection of the stone. So for which the gold standard for detection of renal calculi is a non-contrast CT or a plain CT. Any sort of calculus, plain CT will give you the answer for that. So over here, as we see, and this is a calculus over here in the right ureter. Over here, this is the right kidney showing hydronephrosis. This is the right ureteric cal. This is a sagittal reconstruction showing a right ureteric cal. So, and the advantage of CT is that even those calculi which are claimed to be radiolucent, they will be picked up. So, talking about the renal calculi, what are the routine, common appearances? What are the common? So, talking about the renal calculi, what are the different types of calculi that we see? Radiopaque calculi. So, these are basically calcium phosphate or calcium oxalate. Then you'll have calcium phosphate or magnesium ammonium phosphate. Poorly radiopaque calculi are cystine. And this one is the most important, is non-opaque. I'm saying most important is because this is most important for you from the exam point of view. Non-opaque calculi, which I mean is those calculi which you will not see on your abdominal X-ray. So these are basically your uric acid, your xanthine, and your matrix calculi. So you need to know these three calculi. CT urography. Nowadays, CT urography has more or less, replaced IVP or intravenous pyelography at most of the advanced centers, because CT urography is known to give you more information. So, and obviously you don't need to make the person wait for hours and hours to wait for the contrast to come down, just to see where the level of obstruction is. This is a case of renal when we come down to renal tumors. So on the right side, what we have is a faintly enhancing mass-like lesion occupying the right renal pelvis. So over here, this is on the right side. There's another patient with a similar appearance. This is basically your transitional cell carcinoma. Another patient with a renal cell carcinoma. This is how it appears on the plain scan. And this is over here, it enhances on the arterial scan. The renal cell carcinomas are actually known to enhance more than the transitional cell carcinomas. And over here, this is how it appears on the CT IV urography plate. This is how it is seen to indent the pelvis. Now we come to CT angiography. What is the role of CT angiography in evaluating renal vessels, renovascular hypertension? Now CT angiography will tell you whether there is renal artery stenosis or not. If there's a renal stenosis, you can follow it up with catheter angiography. Catheter angiography will identify the stenosis, and if possible at that moment, if you can either dilate that narrowed segment, or you can insert a stent and cause widening, or you can reduce the stenosis. So this is a case of fibromuscular dysplasia. This is your of the right renal artery. This is your aorta, and over here it gives you that that beading appearance which you typically see with the fibromuscular dysplasia. Once again, this is another patient where you do angiography. If certain renal tumors, they can give you persistent hematuria, so the patient will keep on complaining of hematuria. So if that tumor is non-resectable, what one can do is you can go and embolize the blood supply to the tumor. So these are some of the applications of renal angiography, and this is the role for the interventional radiologist. So, and when we are talking about the genitourinary system, obviously we need to talk about the adrenal glands. And now this was a 10-day-old baby who had come with a palpable mass in the abdomen. Now this was actually, it had turned out to be an adrenal hemorrhage. So what are the various adrenal lesions which are seen in adults? Most commonly it is your metastasis. You can have an adenoma. So for imaging the adrenals, the modality of choice is your CT. If CT does not help, then probably MR may be performed, but most of the time CT will give you the answer. If there's an angiomyolipoma, if that's what you're looking for, then probably CT or MR, both of them might be equal. So there are these certain conditions which I would like to take a recap. Again, renal and ureteric calculi, imaging, ultrasound will give you the exact, the condition of the pelvic elation system, whether there's hydronephrosis or not, whether there is hydroureter or not. If there's a calculus at the vesico-ureteric junction, ultrasound will pick that up, and that could be the end of it. But then, many times ultrasound may not be able to pick up the exact level of, obstruction of the renal calculus. So that's radiograph may or may not be useful, but then a non-contrast CT will definitely do the job for you. Renal neoplasms, ultrasound followed by CT. Renovascular hypertension, you can begin with a renal artery Doppler that will pick up your stenosis, CT angiography, and like I mentioned it previously, a radionucleotide study will definitely help to rule out renovascular hypertension. And of course, there's renal artery stenosis, and which can be correctable. Your renal angiography and renal stenting will help. Certain areas like vesico-ureteric reflux within the pediatric population, that's where your micturating cystourethropy will help. So what you do is you pass in a catheter. Generally, the vesico-ureteric reflux is seen in male patients due to posterior urethral valves. So what you do is you pass in the catheter through the urethra, you fill the bladder till the bladder is full, and then when the child is passing the urine, when the child is voiding, you take the film. So because of that increased pressure due to the posterior urethral valves, you will also see the valves, you will see the bladder, and you will see the urine refluxing within the ureters. The role of ultrasound in vesico-ureteric reflux is if you have to see the length of the kidneys, the scarring of the kidneys, that's what the ultrasound will tell you. Urethral strictures, depending on whether stricture is, if it's in the anterior urethra, your ascending urethrography will help. That is, you cannulate the tip of the urethra and you inject. But if it's a posterior urethral stricture, what you do is, again, your MCU might be equally helpful. Prostate and seminal vesicles, endorectal ultrasound is the way to go. And followed by, if you're suspecting adenocarcinoma of the prostate, then this should be followed up with biopsy. If at all there is still a dilemma, MRI may be helpful. MRI is very good in local staging of CA prostate, and obviously evaluation of the seminal vesicles as well. So after we are done with the genitourinary system, we move on to the skeletal system or the musculoskeletal system. We begin with the plain radiographs, just like always, basics first. And this is your these are your frontal radiographs of both the knee joints. So over here, this is your right side. How do I know this is my right side? Because I see the marker on the right over here. So these are your bones. This is your femur. This is your tibia. This is your fibula. Same thing on the other side. And what I see is what is the alignment of the joint. You know, the joints are properly aligned over here. The marrow appears normal. There is no lytic or sclerotic lesion anywhere. This over here is my patella. This over here, this is the cortex of the femur over here. This is the cortex of the tibia. There's no break in the cortex, or there's no periosteal reaction. Another thing what I would like to see is even try and take a look at the soft tissues around the limb, and there's no calcification or there's no mass-like lesion. So this is basically how you'll be interpreting the radiographs. So once you're done, if you're looking for any particular soft tissue pathology or you're suspecting a cartilage injury or something like that, MRI is a way to go. MRI will give you all the information about the soft tissue masses, the soft tissue lesions, joint effusion, marrow abnormalities, and cartilage. Initially, it was thought that MRI is not a great modality to view the bone, but no, it's not that. If there are any marrow disorders, if there is any infection, then MRI is the way to go. Over here, this is the image of an ankle. So over here, this is my tibia, this is my talus, this is the calcaneum. Over here, this black line is your cortex, and all this is your marrow over here. And these are all your periarticular structures. This is your tendoachilles tendon. This is the fat around the joint, and this is the plantar fascia, and so on. So after that MR, we move on to evaluation of trauma. Trauma, initial modality of choice is always X-rays. X-rays will tell you what is the relation of the fracture. It will diagnose the fracture if at all, if it's there. So for trauma, we begin with the plain radiographs. If there's an obvious fracture, the X-ray will show it to you. It will show you what is the level of the fracture. Is there displacement of the fragments or not? Is it a pathological fracture or not? Or whether it's is there any joint instability or not? So these are the things which you will find out about the X-ray, and obviously the orthopedic surgeons will be doing their planning with respect to the X-rays. And follow-up imaging will obviously help in evaluating the pre and the post-operative appearance. And obviously this is a much cheaper modality to use rather than than CT. Now the role of 3D CT in trauma. 3D CT can be an extremely useful modality in the evaluation of fractures around complex structures, like for instance this mandible over here, or over here around the glenoid. There was an injury due to shoulder dislocation. Now this is the elbow joint. Now these because there's so many overlapping structures. Let me take for example the elbow joint. Smaller fractures might be missed if it's a completely shattered or comminuted fracture. X-ray might not give you that sort of detailed appearance of the anatomy, which this 3D CT will definitely help you, and you will be able to plan your surgery.